Thanks so much for tuning into this presentation. My name is Sarah Tajani and I am a Learning and Curriculum Manager at UBC's Division of Continuing Professional Development. Today, I will be presenting on shaping palliative care CPD by including the patient voice. Before I begin, I'd like to take a moment and acknowledge that I live and work on the traditional, ancestral, and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh First Nations, and for that I am very grateful. I also encourage you to take a moment to acknowledge the traditional lands of wherever you may be at this moment. I'd like to acknowledge my lovely co-authors before beginning this presentation, as well as the Practice Support Program, an initiative of the General Practice Services Committee who has funded the development of this program that I will be exploring with you today. Also, a special thanks to UBC Health Patient and Community Advisory Committee. A little bit of context before I begin. So, to date, patient involvement in CPD has been less developed compared to undergraduate or postgraduate education. Nevertheless, patients, families, and caregivers have been identified as the most important stakeholder in contemporary CPD. Research shows us that patients are less likely to be involved in education planning rather than course delivery, even though this has been identified as an important step towards avoiding tokenism and promoting shared learning. Patient involvement in medical education supports the identification of learning needs and motivates healthcare providers for positive practice change. Recognizing this, in 2018, UBC CPD identified the need for more meaningful engagement of patients in the education planning and development process, and so our journey began. First, it was determined that we would take a more robust approach to integrating the patient voice in redesigning the Practice Support Program's Palliative Care Learning Module for family physicians. This topic was chosen in recognition of the complex nature of patient care with regards to this topic. The differing geographical practices across the province, as well as the spectrum of patients involved as team members in care, including the patients themselves, families, caregivers, and advocacy groups, were thought to be a very complex area to uncover and work with. Next, we sought to develop a partnership with UBC Health's Patient and Community Partnership for Education. This is an academic unit skilled at integrating patients into educational programming at the undergraduate level. It was agreed that the palliative care education was an exciting opportunity to pilot a new approach to integrating the patient voice into CPD. Together, we aim to address the question, how do we engage patients as partners throughout the CPD process? We applied lessons learned about authentic patient involvement from undergraduate education to the design of CPD for family physicians. Meaningful practices were identified through literature review, environmental scan, and interviewing key informants. So we decided to take an approach of including the patient voice in both needs assessment and content development. I'll start with the needs assessment. So in this phase, the redesign process, we tapped into the Patient and Community Advisory Committee, otherwise known as PAC. This is a standing committee of UBC Health as well. With this group, a 90-minute focus group was conducted with 8 PAC members present and an additional 7 patients who were recruited voluntarily, and 2 key questions were discussed. These questions included, what do you believe are the key topics and competencies that family physicians should know about palliative care, and what tools and or resources would be most useful for family physicians and their patients. Findings were anonymously captured and integrated into a summary of recommendations document which was shared with the planning committee. From these recommendations, the planning committee, composed of subject matter experts, educational experts, target audience members, community organizations, and patient advocacy groups, came together to develop a content outline which was fed back to PAC for review and feedback prior to moving into the actual content development stage. So in this Second stage, the palliative education was envisioned as a series of online and in-person small group learning units. So interdisciplinary groups were recruited to collaboratively develop 2 case studies that focused on integrating best practices in team-based care. Recognizing the importance of including the patient as a team member in their care, 2 volunteers from the focus group were sought to support development of each of these case studies. Input was provided during a meeting with theoretical members of a care team, and their feedback was integrated based on this discussion. An additional opportunity for feedback was later provided electronically once additions and changes had been integrated by the education team. So here I have a very high-level summary of our process and approach to integrate the patient voice at various points of the education design and development process. So feel free to pause on the slide if you'd like to read through it, or contact me if you would actually like a copy of this process map. So with all of that said and done, what were our outcomes? Well, we found that engaging patient partners who had been involved in the needs assessment phase was mutually beneficial. Patient partners were able to report back to PAC about their experiences and outcomes. It also enabled continuity throughout the process, allowing UBC CPD to leverage the rapport and understanding solidified in the earlier stages of the project and have almost a check-back mechanism. Additionally, patient involvement in this manner raised awareness of patient perspectives for both the education team and medical leads. Involving the entire project team in the initial focus group enabled more meaningful connection and understanding of the patient perspective. The focus group resulted in a more patient-centric list of considerations and a greater emphasis on the pivotal role that patients and their families and caregivers play as team members in their care. This led to the inclusion of their voices in the team-based care case studies. Physicians involved in the case study development noted that the experience made them reflect on their own clinical practice and things they could do differently. So overall, they found it to be an extremely positive experience for them. The 2 patient partners involved in the development of the case studies, however, reported mixed experiences. One individual found it difficult to see how someone with lived experience could contribute to a case that was more so clinical and really looking at that physician lens, and noted that 2 members, unfortunately, on our call dominated the conversation. The second individual found that their perspective was extremely relevant and welcomed, and they were able to raise additional issues for consideration that was also very much welcomed by the subject matter experts at the table. Neither, however, felt that the feedback loop had been sufficiently closed. This partnership had impacts on UBC CPD at an organizational level as well. This impact resulted in the establishment of division-wide best practices for meaningful patient engagement throughout the CPD planning process, and much work has been done to integrate this into our day-to-day thoughts. How do we include the patient voice at the outset of a project, but also throughout? Finally, I'd like to share a brief overview of the lessons we learned through this process before signing off. So, the first lesson learned was that buy-in is needed from different stakeholders involved. As is normal with change, initially there may be some resistance as you're introducing the patient voice, and also recognizing that there are some assumptions and fears that may come into play with these stakeholders. So these concerns need to be heard and addressed with strong leadership skills before moving forward and including the patient voice. The second lesson learned is that a visioning meeting with the project team members, partners, and experts really helps to solidify clear goals and a structure for moving forward to help avoid tokenism. It is equally important to be flexible and adaptable in order to set processes and meet the project's needs. Third, it's important to set a criteria prior to recruiting patients to ensure meaningful contributions can be made by those who are able to address your project needs. For example, it was especially important in our case to include a diversity of perspectives on controversial issues such as medical assistance in dying. Our fourth lesson learned is as new best practices on compensation emerge, costs really need to be considered at the outset and built into respective budgets. This cannot be said enough. Patients, as your partners, are really lending their subject matter expertise, and as you would compensate a subject matter expert, you should also be doing that for patient partners. The fifth lesson learned was that CPD leaders are really responsible for creating a welcoming and safe space for patients and building that rapport. Patient comfort in participation and safety in disclosure must be respected. Even with patients experienced in healthcare professional education, they also experience power differences and language barriers, and these can inhibit authentic involvement. So it's very important to be mindful of that and really be advocates for the patients at the table. My final lesson learned that I'd like to share is that involving patient partners at any stage in the planning, development, and delivery of education requires an ongoing effort to improve processes. As such, CPD leaders and educators should view the integration of patient involvement in programs as an opportunity to engage in quality improvement, and structured frameworks such as the PDSA cycle may be considered in order to put these into effect. So, all in all, this has been a very fruitful experience for our division, and this is an area that we are excited to continue developing in. We ultimately feel that the lessons learned from our experiences are not specific to our context and are generalizable, and we're always happy to connect if you have any questions, concerns, and we're really hoping to take that quality improvement lens and continue to improve in this area. So thanks so much for taking the time to listen to this presentation, and if you have any questions, please feel free to contact me at sarah.t@ubc.ca. Thanks so much.